started. So hi, everyone. Welcome to the first virtual ward round series on general medicine. My name is Victor. I'm one of the junior doctors working at the Royal Melbourne Hospital. In these virtual ward rounds, I'll try to provide some practical insight into how the theory that you guys have learned from textbooks and online resources, how they can be used to solve real world clinical problems. And today I'll take you guys through 3 interesting and medically complex cases and try to use them as a stimulus to talk about some important clinical concepts. So as you guys are no doubt aware, the virtual ward round series is brought to you by Teaching for Impact, a not-for-profit organization with a mission to use education as a weapon to create meaningful social impact. This year, all of our medicine lectures will be run as fundraising events for the Asylum Seeker Resource Centre, the largest independent human rights organization for people seeking asylum in Australia. As an organisation, we share ASRC's belief that all asylum seekers deserve protection, respect, and a chance to rebuild their lives, and invite medical students from across the state and nation to join us in our campaign to make a meaningful contribution towards this worthy cause. For those of you who are interested in keeping abreast of the tutorials and lectures that our dedicated TFI medicine team has to offer, please scan the QR code on the right. And I guess this evening, my intention is to keep these sessions relatively informal, almost like a casual sort of fireside chat with interested people about interesting medicine. At certain points, I'll put some questions to the floor, and I'll love it if you guys could all contribute answers to the online chat, or for those who don't mind, turn your camera on, unmute and share your thoughts with the group. Just to get the conversation going. All right, so without further ado, let's get cracking with our ward round. So the first patient on the list is a 53-year-old female admitted post a generalized tonic-clonic seizure in the setting of a recent large left MCA stroke on the background of SLE complicated by APS. Now, before I move on, I'm assuming everyone knows what SLE stands for. Yep. Sorry, I should phrase the question. Does anyone know what SLE stands for? Yep, great. Cool. And APS? In this context, APS can stand for a lot of things, acute pain service. But in this context, Antiphospholipid Syndrome, and we'll explore these 2 conditions in a little more detail. So this patient has a past history of AF, SLE with secondary antiphospholipid syndrome, type 2 diabetes, and focal epilepsy. Her pre-admission meds are as shown and include some immunosuppressants for her SLE and some anticonvulsants for her epilepsy, as well as some aperients, presumably for constipation. She's from home with supportive family, is a non-smoker and a non-drinker. Now, there's one antibiotic on the list of medications, Bactrim. Does anyone know what Bactrim is?
Is that TMP-SMS?
Sorry? Yeah, that's right. So 2 antibiotics, trimethoprim and sulfamethoxazole. Anyone know how they work? What the mechanisms of actions are for the 2 drugs that make up Bactrim? So as, sorry, was that Wei Chung?
Yeah.
Yeah, so as Wei Chung was saying, Bactrim is trimethoprim plus sulfamethoxazole. trimethoprim and sulfamethoxazole inhibit separate enzymes in the folic acid synthesis pathway. The result is decreased folic acid synthesis, which is required for bacterial DNA synthesis. Something, just a fun fact to know, is that both trimethoprim and sulfamethoxazole are individually bacteriostatic, but when combined, they become bactericidal. Anyone know what the side effects of trimethoprim are? There are two main side effects that I'm aware of.
Because hyperkalemia, I think trimethoprim can cause.
Yeah, fantastic. Was that Luke?
Yep.
Yeah, so at high doses, trimethoprim can cause hyperkalemia. There's one other. And there's actually a drug that an immunosuppressant that we sometimes use to treat things like rheumatoid arthritis called methotrexate, which sort of has the same mechanism of action as trimethoprim. But both trimethoprim and methotrexate can cause bone marrow suppression. So that's two main side effects of trimethoprim, one at high doses, hyperkalemia, and two, bone marrow suppression. Sulfamethoxazole also has some important side effects. Sometimes, especially the dermatology team, from my experience, they're a bit hesitant to use Bactrim because sulfamethoxazole is associated with, in some patients, a hypersensitivity reaction. So some patients get very severe cutaneous adverse reactions, including Stevens-Johnson syndrome, when they're given sulfamethoxazole. Other side effects include hemolysis, especially if the patient is G6PD deficient, interstitial nephritis, and photosensitivity. But that's as an aside. So let's get back to the case. These are her admission bloods. I think the things to hone in on are that she's anemic and she's thrombocytopenic. And we'll talk about this in more detail, but cytopenias are often associated with well, in SLE, you often get cytopenias. She also has very poor renal function. Now, going back to her past medical history, she has type 2 diabetes, so her renal impairment could be related to her type 2 diabetes, but could also be related to her SLE, which causes lupus nephritis. So she came in post a seizure in the context of a recent left MCA infarct. Reasonable to do a CT brain. Her CT brain showed no acute abnormalities, just an old left MCA territory infarct. So let's take this opportunity to talk a little bit about SLE. So SLE is a chronic autoimmune disease that can affect almost any organ. The classic presentation is that of a young woman of childbearing age presenting with fever, joint pain, and rash. Now, the reason for female predominance remains a little unclear, but the theory is that it may be in part due to the effect of estrogen. They've done studies when patients with SLE, they give estrogen and progesterone hormone replacement therapy in one group and placebo in the other group, and they've found that the risk of an SLE flare is about 1.5 times that of 1.5 times greater risk in those receiving hormone replacement therapy compared to placebo. So there's something about estrogen that predisposes people to SLE. SLE as a disease is caused by the production of auto antibodies against nuclear antigens, or so-called anti-nuclear antibodies, or ANA. Now, on the ward, ANA is a blood test that we commonly order as part of a vasculitic / autoimmune screen. There's actually no single antibody that's called anti-nuclear antibody. So ANA encompasses a plethora of different autoantibodies targeting different nuclear antigens. In the case of SLE, there are two specific anti-nuclear antigens that, when present, are highly specific for the diagnosis of SLE. Does anyone know what those two antibodies are?
Is it the anti-Smith antibody and the anti-double-stranded DNA antibodies?
Yeah, fantastic. So one, anti-Smith antibodies, which are directed against components of the spliceosome, which it resides in the nucleus, and also anti-double-stranded DNA antibodies as well. So the pathophysiology involves these anti-nuclear antibodies, these two main anti-nuclear antibodies binding and forming an immune complex with their nuclear antigens. And then these immune complexes then depositing in different organs of the body to cause disease. So SLE is an example of a type 3 hypersensitivity reaction rather than a type 2. It's important to note, though, that production of ANAs is fairly common in the general population, and not all people who produce ANAs develop SLE, suggesting that there are other factors at play. Just as an aside, has anyone heard of drug-induced lupus? So there's a specific variant of lupus called drug-induced lupus. Does anyone know what drugs actually induce drug-induced lupus? So the two commonly implicated medications are one, an antiarrhythmic called procainamide, and secondly, an antihypertensive, which is more commonly seen, called hydralazine. Yeah, fantastic. Good job, Jason and Alex. Cool. Yeah. So hydralazine, procainamide are the two most commonly implicated drugs, and drug-induced lupus, in contrast to your standard garden variety lupus, are associated with another kind of anti-nuclear antibody. Does anyone know what antibody I'm talking about?
Antihistone antibodies?
Yeah, antihistone antibodies, which is rather specific for drug-induced lupus. But back to the garden variety. So SLE exhibits great variability in clinical manifestations. I won't go through all the possible clinical features, but I have them listed on the slide, but we'll highlight a couple of notable ones. So SLE is associated with a valvular complication called Liebman-Sachs endocarditis, also called verrucous endocarditis. So this term describes vegetations on the undersurface of either the mitral or the aortic valve that develops due to endothelial injury in the setting of a hypercoagulable state, rather than a bacterial infection. Useful to remember that SLE is associated with LSE, so Liebman-Sachs endocarditis. Now, the other thing that I want to highlight is that SLE is also commonly associated with a condition called Antiphospholipid Syndrome, which causes patients to be at risk of clotting. And I'll talk about Antiphospholipid Syndrome a little later in more detail. And finally, the thing to point out is that patients with lupus nephritis or CNS lupus, so lupus in the kidneys or lupus in the brain, have increased mortality. So out of all the organ systems that can be affected with SLE, lupus in the kidneys and lupus in the CNS suggests badness. And in our lady, so remember, she came in with a seizure. The seizure could have been triggered by either the left MCA infarct, or it could be a manifestation of CNS lupus. In this case, she was reviewed by the rheumatology and neurology teams, and actually their impression was that this her presentation was quite consistent with CNS lupus. She also has really bad kidneys, and as we discussed, this could be due to type 2 diabetes. It could be a manifestation also of lupus nephritis. So our lady, Mrs. AB, seems to have both CNS lupus and lupus nephritis, which equals extra badness for her prognosis. So the diagnosis of SLE, usually made based on a combination of history, examination, and laboratory tests. So in a patient presenting with fever, rash, and joint pain suspected to have lupus, The evaluation usually involves firstly interrogating the patient on the different clinical features of SLE, which was listed in the previous slide, examining the patients for signs of SLE, and then ordering a panel of blood tests to look for other manifestations of SLE. Now, if you were, say, the rheumatology resident that was running sort of rheumatology outpatient clinic on a Thursday morning, and you have a lady come through your doors, a lady, childbearing age, presenting with fever, rash, and joint pain, you're suspecting SLE, what panel of blood tests would you order to try to establish that diagnosis? Just suggest a couple of blood tests and then like why? What are you looking for? Yep. So Joyce says UAC. What are you looking for on UAC, Joyce? Yep, renal disease. Cool. And you said FBE. What are you looking for there? Yep, anemia, leukopenia, thrombocytopenia. Cool. Anything else? You're trying to confirm the diagnosis of SLE. You've taken the history, done the examination. Yep. So, yeah, anti-Jo1, anti-double-stranded. I think so. Commonly, you would order an ANA, which basically comes back positive if the patient has any anti-nuclear antibodies, and then often you'll also order what we call an ENA. So ANA is usually paired with an ENA, and it's kind of like FBE with differential, really. So when you pair an ANA with an ENA, the ENA tells the lab, I want you to test for the presence of specific anti-nuclear antibodies, and as part of an ENA panel, there are around six commonly seen anti-nuclear antibodies that are part of the ENA panel. So they're anti-Smith antibody is part of that. Anti-Ro, anti-La is also part of an ENA. Anti-Jo1 is also part of an ENA as well. Anti-double-stranded DNA is not, though. So on a path slip, you'll write ANA plus ENA. ENA will include Jo1 and also anti-Smith. You'll order separately anti-double-stranded DNA, which is positive in 70% of patients with SLE. And yeah, so yeah, anti-Smith as well, which is part of your ENA.
Would you do ANCA for patients?
Yeah, if you're
who
suspecting
have SLE.
Yeah. So if you're suspecting an ANCA-associated vasculitis, you will. So ANCA is part of any sort of autoimmune screen. So is very commonly ordered. The other I guess must-haves would be CRP and ESR, which you would expect to be elevated in SLE. You'll look for C3 and C4, so the two complements, and a urine MCS albumin creatinine ratio, so ACR, and protein creatinine ratio, PCR, to look for hematuria or proteinuria that might be suggestive of lupus nephritis. So anyway, so you've examined the you've taken the history, you've examined the patient, you've ordered the blood test. The blood tests usually take a couple of days. Like the common blood tests, can come back in a matter of hours. But things like ANA, ENA, anti-double-stranded DNA, usually it takes a couple of days to come back. But in order to establish the diagnosis of SLE, often people use there are different criteria that are used, but often people use the old school American College of Rheumatology or the ACR criteria, which I've listed on the slide. So it says that you can diagnose SLE in the presence of at least 4 of 11 criteria, 4 of which are related to the skin, 4 of which are related to organs other than the skin, and 3 of which are laboratory test results. So the 4 related to the skin, malar rash, which is your standard butterfly rash, discoid rash, photosensitivity, and oral or nasal ulcers. The 4 related to organs other than the skin, arthritis, commonly non-erosive in nature, serositis, and what we mean by that is either pleurisy or pericarditis, renal disease, so lupus, evidence of lupus nephritis, or neurological disorder, CNS lupus causing seizures, psychosis, etc. And the 3 laboratory tests are hematologic disorders, so cytopenias, immunologic disorders, so the 2 specific antibodies, double-strand DNA and anti-Smith, and also, commonly about 40% of patients with SLE have secondary antiphospholipid syndrome. So you'll often also send off antiphospholipid antibodies as well. And that's part of the criteria. And, as I said before, most patients are ANA positive. Cool. So the thing to note about the ACR criteria, although it's commonly used to diagnose SLE, it doesn't capture all of the possible clinical features of SLE, as you may have noticed. So it captures only the most common ones. All right, a quick word about how we manage SLE. So management of SLE can be divided into non-pharmacological and pharmacological. So non-pharmacological, I've listed those the things to consider there. I guess a word about smoking cessation. So smoking in SLE is bad for 3 reasons. So firstly, it's associated with more active disease in SLE. So if you're an SLE patient and you smoke, you'll get SLE flares more frequently. Secondly, it adds to the baseline increased risk of coronary artery disease. So SLE patients, for some reason or other, are at increased risks of having a heart attack. And smoking further increases that baseline risk. And the third is that, so we'll get to treatment, but the first line agent to treat SLE is an anti-malarial medication called hydroxychloroquine, or the trade name for that is Plaquenil. Smoking has been demonstrated to diminish the efficacy of hydroxychloroquine. In patients with new diagnosis of SLE, very important to counsel the patient to stop smoking entirely. The other interesting thing is that allergies to antibiotics are more common in patients with SLE for some reason, with up to 30% of patients having an allergy to sulfonamide-containing antibiotics, including Bactrim. And this will become important a little later on. In terms of pharmacological management, so as I said, the first line pharmacological treatment is hydroxychloroquine or Plaquenil. Does anyone know any side effects of Plaquenil? There are 3 that I have in my head. Yes, retinopathy, cool. Yep, visual problems, retinopathy. It's one of the 3. So the second is hemolysis, especially in patients with G6PD deficiency. I'm going to mention G6PD deficiency quite a few times this lecture. And the third is pruritus, especially in patients with darker skin. So hydroxychloroquine is first line. Additional therapy is based on severity of disease. So often you need to add in other immunosuppressants as well, including things like azathioprine, methotrexate, mycophenolate mofetil, cyclophosphamide, and rituximab. So going back to our patient, so she has a history of SLE, and so is expectedly on hydroxychloroquine, which is the first line agent to treat SLE. But the fact that she's on high dose prednisolone and also mycophenolate mofetil, suggest that she has rather severe SLE, which is also reflected in her bloods, which show an EGFR of 15, likely secondary to lupus nephritis. So what's interesting is that there's no indication on history. So she came in with a seizure. There's no indication on the history examination or bloods that that this patient has an infection. So why might Bactrim be on her list of medications? Fantastic. Yes, PJP prophylaxis. So PJP is Pneumocystis jirovecii. It's a yeast-like fungus that can cause a diffuse interstitial pneumonia, particularly in immunosuppressed patients. Manifests as diffuse bilateral ground glass opacities on chest imaging. And I think, especially for the final years on this call, I think a piece of trivia that you should bear in mind for next year is that PJP prophylaxis is generally recommended for all patients on prednisolone at a dose of more than 20 milligrams daily for more than 4 weeks. And you'll see a lot of these patients. So more than 20 milligrams of prednisolone daily for more than 4 weeks warrants consideration of PJP prophylaxis. The first line agent for PJP prophylaxis is Bactrim. Although, as I mentioned, some patients with SLE have an allergic reaction to sulfonamide-containing antibiotics, such as Bactrim. And so often in these patients, we need to go to the second line agent for PJP because they're allergic to Bactrim. Do you guys know what the second line agent is for PJP prophylaxis? It's also used in the treatment of PJP, so the combination of Bactrim and this medication. It's called dapsone. Yeah, fantastic. So we'll talk about dapsone a little in more detail a little later on. So another question about this particular patient is why might this patient be on warfarin?
They have AF.
Was that Matt? Yeah, they have AF. So as you know, patients with AF with a CHAD-SVAS score of greater or equal to 2 in men, greater or equal to 3 in women, need to be placed on oral anticoagulation to prevent strokes. But you might also know that warfarin is only really used in patients with valvular AF. And does anyone remember what we mean by valvular AF?
I think that's with AF with mitral stenosis, or if they have artificial heart valves. Absolutely,
yeah. So two things that we mean when we say valvular AF. So person with AF with either moderate or severe mitral stenosis or a mechanical heart valve. This patient has neither of those things. So usually in that context, for non-valvular AF, NOACs are usually preferred, although you can still use warfarin, but NOACs are preferred because patients who are on warfarin need to go to their local path clinic or their GP to get routine INR testing. And initially, every couple of days, and then every couple of weeks. But it's quite a burden for some patients, and so usually we prefer to put these patients on NOAC. So we have a patient here with non-valvular AF. Why might she be on warfarin instead of NOAC? And someone suggested antiphospholipid syndrome, which is actually the answer that I'm getting to. Can someone think of another reason why she might be on warfarin rather than NOAC? And has something to do with her bloods. When are NOACs contraindicated?
A really poor creatinine clearance. I think below
Yeah.
30.
Absolutely. Apixaban from memory is contraindicated in a creatinine clearance of less than 25, and then dabigatran and rivaroxaban are contraindicated when creatinine clearance is less than 30. This patient has an EGFR of 15. I wouldn't be surprised. So usually to calculate creatinine clearance, you'll jump online. There's an MD calculator that uses what we call the Cockcroft-Gault equation to calculate the patient's creatinine clearance based on patient's age, sex, height, weight, and creatinine. If you actually, type that all into MDCalc and let it spit out a creatinine clearance, I wouldn't be surprised if this lady has a creatinine clearance of less than 25. So one other plausible explanation is that the GP probably, she was probably on NOAC to begin with, but then the GP probably switched her to warfarin in the setting of rapidly deteriorating renal function, because DOACs are contraindicated in severe renal disease. Warfarin is actually serving multiple purposes in this particular patient, and Jason suggested antiphospholipid syndrome as one of the other reasons why she might be on warfarin. So antiphospholipid syndrome, as I mentioned earlier, 40% of SLE patients have secondary antiphospholipid syndrome. Antiphospholipid syndrome is a chronic autoimmune disease that's caused by the production of autoantibodies against phospholipid binding proteins. And we collectively call these autoantibodies antiphospholipid antibodies. And the presence of antiphospholipid antibodies predisposes these patients to all kinds of clots. So arterial clots, venous clots, small vessel clots. And in pregnant women, it also predisposes to pregnancy morbidity as well. In a patient with SLE, or in a patient with, who come in, I have a patient on our unit at the moment who came in with extensive thrombotic disease. So had clots in his basilar artery, his lungs, his spleen, his kidneys, his femoral artery, and also most recently his right upper limb, one of the right upper limb veins. He developed a DVT. In such a patient, in the current climate, the first thing that we would think of is VIPIT, so vaccine-induced thrombotic, immune thrombotic thrombocytopenia. But this patient was a 80 something year old man, hadn't had AstraZeneca before. So the other thing that you would think of in this context is does this patient have antiphospholipid syndrome? And when you're suspecting antiphospholipid syndrome, you might be called upon to order an antiphospholipid screen. And this screens for the presence of one of 3 antiphospholipid antibodies. Does anyone know what the 3 antiphospholipid antibodies are off the top of their heads? Yep, anticardiolipin, lupus anticoagulant, and one more. Yep, it's the long one. Yeah, anti-beta-2 glycoprotein 1 antibodies. So lupus anticoagulant, we usually test for, so it's called lupus inhibitor screen, and it's usually the blood test that actually the results come back the quickest. So it's actually taking, it's like a standard APTT test. So when you order a coagulation screen, as you probably know, it comes back with PT, INR, APTT, and fibrinogen. And with the APTT, what they can do is a mixing study. Where the APTT TT might be elevated, and then you mix it with normal serum and see if it corrects. And if it doesn't correct, that's suggestive of a either a factor inhibitor in the blood, So like an inhibitor of factor VIII, for instance, or a lupus and anticoagulant. This usually comes back. You read off the mixing APTT test, and usually is the quickest to come back. And then there are two other antibody tests that you need to order: anticardiolipin and anti-beta-2 glycoprotein 1, and these usually take forever to come back. I mean, I ordered these blood tests on this patient that I'm talking about like last week, and it still hasn't come back, but is necessary for the diagnosis of antiphospholipid syndrome. So speaking of which, we diagnose antiphospholipid syndrome using a set of criteria called the revised Sapporo criteria, which states that to make a diagnosis of antiphospholipid syndrome, you need at least one clinical criteria and one laboratory criteria on at least 2 occasions, 12 weeks apart. So the clinical criteria, there are 2. At least 1 clotting episode, so it can be an arterial clot, venous clot, or a small vessel clot, or a pregnancy morbidity. There are 3 laboratory criteria that correspond with the 3 antiphospholipid antibodies. So you need 1 clot and then 1 of the 3 antiphospholipid antibodies to be positive. You retest in 12 weeks, and if they're still positive, then you have a diagnosis of antiphospholipid syndrome. So the thing to remember about the treatment of antiphospholipid syndrome is that so if a patient is suspected to have antiphospholipid syndrome but has yet to develop any thrombotic events, we don't routinely use any medication for primary thrombosis prevention. But if a patient has already been diagnosed with antiphospholipid syndrome and has had a clot in the past, then we need to use oral anticoagulants for secondary thrombosis prevention to ensure that they don't develop another clot. The important thing to bear in mind is that it's been definitively shown over the past maybe 5 years that warfarin is superior to NOACs for secondary thrombosis prevention in patients with antiphospholipid syndrome. And this is especially the case in patients with what we call triple antibody positive antiphospholipid syndrome. So all 3 sort of lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1, all 3 of them are positive. Or in patients with a history of arterial thrombosis, as opposed to just venous events or small vessel events. So I've shown here one of the sort of seminal papers in Blood demonstrating superiority of warfarin over the DOAC rivaroxaban. So in summary, in Mrs. AB, warfarin is serving 2 purposes. So firstly, stroke prevention in AF. And in her case, warfarin was probably the right agent to put her on in the context of her significant renal impairment. And secondly, it's also serving the purpose of secondary thrombosis prevention in antiphospholipid syndrome. And it's actually quite concerning that this patient has still developed a large left MCA clot in the setting of appropriate anticoagulation. Cool. So bit of a break from me just talking. So pop quiz, which 2 anti-nuclear antibodies are highly specific for SLE? And feel free to just write stuff on the chat or unmute and respond. Anti-Smith, anti-double-stranded DNA, cool. Which anti-nuclear antibody is highly specific for drug-induced lupus? Antihistone, cool. What valvular pathology is commonly associated with SLE? Lyman-Sachs endocarditis, cool. So LSE in SLE. How do you diagnose SLE based on ACR criteria? This probably requires a bit of writing, but 4 dermatological, 4 visceral, and 3 laboratory criteria. And you need at least 4 of the 11 to diagnose SLE. What's the first line treatment for SLE? Absolutely. Trump's medication. Hydroxychloroquine. So can you repeat how we diagnose SLE? Yeah, so this slide here. So there are 11 ACR criteria. So the presence of, and it doesn't need to be of a specific category. So the presence of any 4 of the 11 gives you a diagnosis of SLE. Does that clear that up? Yep. Cool. So what are the 3 main side effects of hydroxychloroquine? So 1, retinopathy, 2, pruritus, 3, hemolysis. Good, especially in patients with G6PD deficiency. For a patient on prednisolone, at what point would you consider commencing a patient on PJP prophylaxis? And this will come up quite a few times in your intern year. Yes, 20 mgs of pred for 4 weeks. Cool. What's the first line agent for PJP prophylaxis? Bactrim. And what's the second line agent? Dapsone. Fantastic. What are the 3 antiphospholipid antibodies? It's a mouthful, but lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1. And how do we treat antiphospholipid syndrome? Oh, well, I should rephrase that. What do we use for secondary thrombosis prevention in antiphospholipid syndrome? And the thing to remember is warfarin, never a NOAC. Cool. Okay, let's move on to the next patient. Second patient is Mr. CD, a 76-year-old male admitted with a blistering rash after initiation of vancomycin for clostridium difficile infection in the community that developed following a course of Augmentin Duofort prescribed for community-acquired pneumonia. Cool, lots to unpack there. Past history is significant for multiple cardiovascular risk factors, type 2 diabetes, ischemic heart disease, hypertension, hypercholesterolemia. He's on appropriate therapy for all those things. It's from home with wife. He's an ex-smoker, which is also a cardiovascular risk factor, and a social drinker as well. So the first thing that I might talk about is Clostridium difficile infection, which you will see a lot of as an intern, because a lot of your patients will be on antibiotics. So there are 3 things that you need to know about Clostridium difficile. So the first thing that you need to know is that it's spore forming. So what does this mean? The bacteria can exist in 2 different forms. So a vegetative form and a spore form. And outside the colon, the bacteria survives in spore form. So spores are resistant to heat, acid, and antibiotics. So the usual sort of, a pathophysiology is, an unsuspecting patient ingests Clostridium difficile spore. The spore travels to the intestine. In the intestine, the bacteria then converts into its fully functional vegetative form and becomes susceptible to killing by antibiotics. Now, it's important to remember that Clostridium difficile is spore forming, not just for academic purposes, but it's clinically relevant as well, because you need to remember that every time after you see a patient with Clostridium difficile infection, so these patients will be on strict contact precautions, but every time, just in addition to contact precautions, after you see a patient with Clostridium difficile infection, you need to perform hand hygiene with soap and water rather than just using one of those alcohol-based hand sanitizers, because spores are resistant to killing by alcohol. The last thing that you want is for a few spores to have made, after you examine a patient with Clostridium difficile infection, for a couple of spores to latch onto your hands, you not washing your hands thoroughly with soap and water, and you ingesting that spore and giving yourself that infection. So that's the first thing that you need to know about Clostridium difficile. The second thing that you need to know is that Clostridium difficile is an obligate anaerobe, a strict anaerobe, which means that it can only grow in the absence of oxygen, and that it finds oxygen toxic. So why is this important to know? Because it has implications for treatment of Clostridium difficile. So strict anaerobes like Clostridium difficile, they express an enzyme called pyruvate ferredoxin oxidoreductase. Now, PFORP in short, is the abbreviation. And this P4 enzyme reduces, its function is, it reduces any oxygen molecules that enters the bacterial cell. So it's a survival mechanism, the expression of this enzyme. It ensures that, if some rogue oxygen molecule manages to diffuse, through the bacterial cell wall and get into the cytoplasm of the bacteria, that it can be quickly reduced so that it doesn't become, doesn't kill the bacteria due to its the toxic effects of oxygen on strict anaerobes. Now, this P4 enzyme is also the enzyme that activates metronidazole. So metronidazole is a prodrug, and it only gets activated by P4. So this explains why metronidazole is active against strict anaerobes, and it's only really used in the treatment of obligate anaerobes. Do you guys remember? So there are three clinically significant obligate anaerobes that you use metronidazole to treat. Clostridium difficile is one. Does anyone know what the other two are? So there's a disease called amoebic dysentery that's caused by Entamoeba histolytica. We treat using metronidazole as well, the strict anaerobe. Something called trichomonas vaginalis as well, which we treat using metronidazole. Anyway, so that's the second thing that I want you guys to know about Clostridium difficile. The third thing to know about Clostridium difficile is that it is a gram-positive rod, and there aren't actually that many gram-positive rods out there. So there are only really 5 clinically significant gram-positive rods. And I remember the gram-positive rods using the acronym A, B, C, D, and L. So A stands for actinomyces, B, bacillus, so bacillus cereus, the bacteria that causes, that's found in fried rice and causes food poisoning. C stands for clostridium, and there are Clostridium difficile isn't the only clostridium in existence. There's others as well. Clostridium tetani, which causes tetanus, Clostridium perfringens, which causes gas gangrene, etc., etc. D stands for diphtheria. Diphtheria is not, diphtheria is the disease. It's caused by a bacteria called a Corynebacterium diphtheriae, but that doesn't really work for the acronym. So D stands for diphtheria, and L stands for listeria monocytogenes, causes things like meningitis in immunosuppressed patients. So, Clostridium difficile infection, as you guys all should know, is associated with antibiotic use. So the antibiotic sort of, kills the, bug causing the community-acquired pneumonia, but also kills, all the normal flora in your gut, allowing Clostridium difficile to grow out. There are 4 classes of antibiotics that are commonly implicated in Clostridium difficile infection. Do you guys know which 4 classes? What are the C's, Jason? So, yep, ceftriaxone, actually all cephalosporins. So that's one class of antibiotics. So cephalosporin is one. What are the other 3? Clindamycin, fantastic. 2 more. Co-amoxiclav, yep. So augmentin duofort, so amoxicillin plus clavulanic acid, belongs to a class of antibiotics called penicillins. And so penicillins is the third class of antibiotics. Also part of this class includes things like tazocin or piptaz, piperacillin tazobactam, very commonly associated with Clostridium difficile. And if you remember the story of our patient, Mr. CD, he had augmentin duofort for a community-acquired pneumonia, and that precipitated the Clostridium difficile. So definitely. So yeah, so there's really no difference between augmentin and augmentin duofort. So augmentin duofort is a trade name. It usually refers to the oral form of augmentin duofort, of amoxicillin plus clavulanic acid. You can also give augmentin IV as well. So in that context, you don't really use augmentin duofort. You call it IV augmentin. Cool. So yeah, the last class of antibiotics. So clindamycin, cephalosporins, penicillins like augmentin duofort and tazocin, and the 4th class is fluoroquinolones. So things like ciprofloxacin, things like moxifloxacin, etc., etc. So 4 classes of antibiotics that are commonly implicated in Clostridium difficile. So the thing that you may or may not be aware of is that there are actually 2 different strains of Clostridium difficile. So most, like 70 to 90% of Clostridium difficile are toxigenic, which means that they produce toxin. But there are also some, so 10 to 30% of Clostridium difficile organisms that are non-toxigenic, which means that simply culturing Clostridium difficile on stool MCS isn't sufficient to diagnose Clostridium difficile infection, because you could be culturing a non-toxigenic strain, and non-toxigenic strains don't cause Clostridium difficile infection. In contrast, toxigenic strains of Clostridium difficile release, so most of them release 2 quite potent exotoxins. So one called toxin A and the other called toxin B. Both of them bind to receptors on intestinal epithelial cells, are then taken into the cells, activate there's a row family of GTPases that the toxin activates, and that causes cell death. Now, the thing to note is that of the 2 toxins, toxin B is about 10 times as potent as toxin A, and it is toxin B whose gene we routinely test for in the lab to determine whether a Clostridium difficile organism is toxigenic or not. Now, so out of interest, there's also been this hypervirulent strain of Clostridium difficile that's been around for the past about 15 years called NAP1 or ribotype 027. And this one is, this strain of Clostridium difficile is particularly hypervirulent because it can produce a third toxin called the binary toxin, which is absent in all other strains of Clostridium difficile. Now, why is all of this theory important? So all this theory informs us, informs how we diagnose Clostridium difficile infections. So to diagnose Clostridium difficile infections, you need to firstly have a patient who has been on a culprit antibiotic. So the four classes of antibiotics. So a patient who has been on a culprit antibiotic and is having at least 3 loose stools in 24 hours. So that's the clinical criteria for that would trigger suspicion for a Clostridium difficile infection. So, if you have a patient, been on a course of antibiotics, starts developing this diarrhea, more than 3 loose stools in the past 24 hours, you'll suspect Clostridium difficile and then ask the nurses to send away a stool MCS. Now, the stool sample is then, collected, sent to the lab. The first thing that they do is culture. Do a screening culture of that stool sample to determine the presence of Clostridium difficile. The next thing that they do, so remember, just culturing Clostridium difficile doesn't diagnose Clostridium difficile infection because you could be culturing a non-toxigenic strain of Clostridium difficile. So then the next thing that they do is a PCR to look for the presence of the toxin B gene. If the toxin B gene is present, then that means that your Clostridium difficile is toxigenic, which means that you can diagnose Clostridium difficile. So in summary, to diagnose Clostridium difficile, you need to have a patient with symptoms plus positive culture for Clostridium difficile plus positive PCR for the toxin B gene. There's another way of diagnosing Clostridium difficile, which is to do a colonoscopy or a biopsy of the intestine. And if you see pseudomembranous colitis, then the diagnosis of Clostridium difficile is a no-brainer. But in clinical medicine, no one really does a colonoscopy for suspected Clostridium difficile. So you almost always diagnose it the first way. So how do we treat Clostridium difficile infection? So we talked about one antibiotic that we can use, metronidazole, which is activated by the P4 enzyme. What other antibiotics can we use?
Sorry, Victor, I just had a quick question.
Yeah.
Just with the timeline between getting the positive culture, would you also get them to add on the PCR, or is it like
it's reflex? Confused. It's reflex.
Okay. Yeah.
So you send off stool MCS. They will if they culture Clostridium difficile, the lab will automatically run the toxin B gene PCR. So you don't need to specifically request that. Cool. So other antibiotics that we can treat. Why is metronidazole effective against obligate anaerobes again? Because obligate anaerobes, they hate oxygen, so they express an enzyme called P4 to reduce oxygen. P4 is also the enzyme that activates metronidazole. So metronidazole itself is a prodrug, so it's not an active drug, needs to be activated by the P4 enzyme in order to work. And so metronidazole is only really activated in strict anaerobes. It doesn't really work on non-strict anaerobes or other antibiotics, other bacteria, if that makes sense. Yeah. Cool. So oral vanc. So metronidazole, vancomycin, any other antibiotics or treatment regimens that we could give patients with Clostridium difficile infection? Are you guys aware of? Metro and Vanc are the two big ones. Could you re-explain what you said about culture not detecting toxigenic Clostridium difficile? Okay, right. So the clinical scenario is usually a patient who has been on antibiotics for a couple of days and then starts developing diarrhea. you suspect in that clinical context Clostridium difficile. You ask the nurse to take a stool sample to send off for stool MCS. So that stool sample then gets collected, gets sent to the lab. The first thing that they do is a screening culture. So they take the stool sample and culture it. That will tell you whether you have whether the patient has Clostridium difficile in their stool or not. So you will be able to see, you can do a gram stain and be able to see the Clostridium difficile organism. But that alone is not sufficient to diagnose Clostridium difficile infection, because the Clostridium difficile that you've cultured can be a non-toxigenic strain. So the next step is for you to actually confirm that the Clostridium difficile that you saw on culture is a toxigenic strain of Clostridium difficile rather than a non-toxigenic strain. And the way that we do that is we run a PCR on the toxin B gene, and if the toxin B gene is present, then you can be sure that the Clostridium difficile that you've cultured is a toxigenic strain, and you diagnose Clostridium difficile infection. Does that clear that up? Yep. Cool. Yes, fidaxomicin. Well done, Elizabeth. And yeah, fecal microbiota transplant. So yeah, those are the 4 treatment options for people with Clostridium difficile infections in ascending order of severity, I guess. Metronidazole, vancomycin, and then fidaxomicin, or a fecal microbiota transplant. So I think you guys seem to be all on top of management of Clostridium difficile infection. Just a couple of words. So again, divide into non-pharmacological, pharmacological. So if you have a patient who has confirmed Clostridium difficile infection, the first thing that you want to do is cease the inciting antibiotic. This patient, if you remember, this patient still had vancomycin as part of her medications. So if you're admitting this patient onto the Gen Med unit, the first thing that you will do is stop the vancomycin. Oh, sorry, no, my bad. The augmentin, sorry, the augmentin duophort was probably already stopped by the GP. So backtrack a bit. So this patient had augmentin duophort for a community-acquired pneumonia. Presumably they went to the GP to get the script for augmentin duophort. A couple of days later, developed a bit of diarrhea, went back to see their GP, stool MCS sent away, and the GP, the first thing that the GP would have done is stop the augmentin duophort. The stool MCS usually takes, usually you get the result overnight. Patient makes another appointment to see the GP, Clostridium difficile infection diagnosed, and the GP would have placed the patient on oral vancomycin. So oral vancomycin is appropriately part of the patient's admission medications. So the first thing to do is cease the inciting antibiotic, which the GP should have already done. Now, if the patient were in hospital, as we were discussing, we will put them on contact precautions, which means you need to gown and glove before entering the room. And you need to ensure that everyone who comes in contact with the patient washes their hands with water and soap rather than just alcohol-based hand sanitizers to get rid of spores, because spores are resistant to alcohol. So as we were saying, in terms of pharmacological management, there are 4 main antibiotics that we, 4 main treatment options for Clostridium difficile infection. 1, metronidazole, 2, vancomycin, 3, fidaxomicin, and 4, fecal microbiota transplantation. Now, the choice of antibiotics depends on the severity of disease. So I guess, you have a patient with a new diagnosis of Clostridium difficile infection. The first thing that you need to work out is whether the patient has fulminant, what's called fulminant disease or non-fulminant disease. And what we mean by fulminant disease is you need to ask yourself, does this patient have 1, hypertension or shock, 2, an ileus from their Clostridium difficile infection, or 3, a toxic megacolon, which is often a complication in very severe Clostridium difficile infection. If the answer is yes to any of those things, then the patient has fulminant disease and needs to be treated in hospital. with oral vancomycin plus IV metronidazole for 14 days. Sometimes it gets so out of hand that the patient actually needs to get a colectomy. If the patient doesn't have fulminant disease, and most patients won't, we then further divide non-fulminant disease into severe or non-severe. And there are various ways, various criteria they can use to determine whether the patient has severe or non-severe Clostridium difficile infection. One very simple way is to look at the white cell count and the creatinine. So if the patient has white cells above 15 or creatinine of above 133, and it's a weird number, but it's converted from the American creatinine, then the patient has severe disease, and we usually treat these patients with oral vancomycin for 10 days. Now, this is the treatment regimen that our patient was on. If the patient doesn't have severe disease, so white cells less than 15, creatinine less than 133, then the patient has non-severe disease and can be treated with just oral metronidazole for 10 days. So non-severe disease, oral metronidazole for 10 days, severe disease, vancomycin, oral vancomycin for 10 days, and fulminant disease, you need both oral vancomycin and IV metronidazole for 14 days, and if it gets out of hand, you need surgery. Now, sometimes the patients are refractory to these antibiotics. Or sometimes, these antibiotics work and then the patient relapses. And a relapse, technically speaking, the definition of relapse is an episode within 2 months of the previous episode. So if you have a patient who had a bout of Clostridium difficile, it resolved with metronidazole, 10 days of metronidazole, and then after 4 weeks, he has another bout of Clostridium difficile, then we say that the patient has relapsed because it's within 2 months. Now, if the patient is refractory to these antibiotics or relapses, then the preferred treatment is a fecal microbiota transplantation. And I have to say, I've never seen one of these. I'm not sure how readily available they are. When I was part of the ID unit earlier this year, I had a patient with refractory Clostridium difficile infection, was for consideration of fecal microbiota transplantation, ultimately decided that logistically it was too difficult to organize. And so we placed the patient on another antibiotic called fidaxomicin for 10 days, and that did the job. So if the patient is refractory or has relapsed Clostridium difficile, then the first line is fecal microbiota transplant. If that's not available, then we use fidaxomicin. Now, yeah, absolutely. Yeah, there are many other antibiotics that we can use to treat community-acquired pneumonia empirically. This patient didn't have any sputum cultures that we were aware of. Actually, this patient's community-acquired pneumonia actually resolved with the course of Augmentin Duofort prior to his admission. So his real presenting complaint was, well, to the GP, was Clostridium difficile infection. And that remained an issue during his stay with us. But actually, sorry, his real presenting complaint to the hospital is this blistering rash after his GP prescribed him vancomycin, which we'll talk about. Could you repeat what you said about relapse and something about 2 months? Yeah, yeah, if you have an episode of Clostridium difficile and that resolves with metronidazole, and then 4 months later you develop another Clostridium difficile infection, we don't call that a relapse. It needs to be within 2 months. So if you have an episode of Clostridium difficile infection and then 1 month later you develop another episode of Clostridium difficile infection, then we call that a relapse. Cool. So this is the patient's presenting complaint. This blistering rash that developed on the dorsum of the patient's right hand a couple of days after commencing vancomycin for his Clostridium difficile infection. And the rash actually proceeded to spread all over his body. Extremely painful for the patient, and it's painful to look at. Any thoughts on what this might be? Has anyone seen something like this in the hospital? Dress, yeah. The blister isn't classic for dress. Yeah, red man syndrome is a well-known side effect of vancomycin. Red man isn't that dangerous. You just get erythema around the body, but it doesn't blister like this. Stephen Johnson is a good thought. Again, if you look at pictures of Stephen Johnson syndrome, this isn't classically. Stephen Johnson syndrome looks very different from this. Bullous pemphigoid. Lakshay, you are on the money. Lakshay, have you seen a case of bullous pemphigoid?
Oh no, but someone just told me about it a couple of years back, so I just remembered it.
Yeah, tense looking blister like that. Think bullous pemphigoid, and indeed, so this patient was appropriately seen by dermatology on day one of admission. And actually the dermatology registrar who saw this patient, her first thought was also bullous pemphigoid. And I think it may be worth having a quick chat about autoimmune blistering skin disorders. So there are two main autoimmune blistering skin disorders that you need to know about. So one is pemphigus vulgaris, which is potentially fatal, very severe condition. And the second is bullous pemphigoid, which Lakshay mentioned. It's less severe, but still annoying, as you might anticipate. So to understand how these two conditions are different, I think it might be worth briefly revising some undergrad molecular biology. So epithelial cell junctions. So I guess on the right I have a diagram of two epithelial cells in the epidermis of the skin, and then the green part is the basement membrane that underlies it. Now, if you remember, there are desmosomes. So desmosomes connect adjacent epithelial cells together. And then there are hemidesmosomes that connect the epithelial cells to the basement membrane. So desmosomes connect epithelial cells together, and then hemidesmosomes that connect individual epithelial cells to the basement membrane. Now, pemphigus vulgaris is caused by IgG autoantibodies against desmosomes, which lie between epithelial cells. Specifically, the antigens are desmoglin 1 and desmoglin 3. Now, pemphigus vulgaris classically produces a flaccid bully or blister, and I've included a photo of an example of pemphigus vulgaris. It looks quite different. It's a flaccid bully, not a tense bully like the one we have. And classically, pemphigus vulgaris involves the oral mucosa. And I'm not sure if you guys have heard of Nikolsky sign, but there's a bedside test that we actually never do, but can be done and is classically in textbooks and stuff. It involves kind of placing the eraser of a pencil on the roof of the lesion, and then spinning a pencil in a rolling motion between the thumb and the forefinger and seeing whether the skin sloughs off. And if the skin sloughs up, then we call it Nikolsky sign positive. If it doesn't, then it's Nikolsky sign negative. And it makes sense that pemphigus vulgaris would be Nikolsky sign positive because you have autoantibodies attacking desmosomes between epithelial cells. So if you agitate the epidermis a bit, the epidermis will slough right off. Now, if we take a skin biopsy, which is how we diagnose these conditions, a punch biopsy, and perform what we call direct immunofluorescence to actually visualize the culprit autoantibodies, in pemphigus vulgaris, we classically see this reticular pattern around epidermal cells. And this also makes a lot of sense because the autoantibodies in pemphigus vulgaris are directed at the desmosomes that lie between cells. So in green here are all the autoantibodies that are binding to desmosomes between individual epithelial cells. So this reticular pattern seen on direct immunofluorescence makes sense. Now, in contrast, bullous pemphigoid, as I said, is less severe than pemphigus vulgaris. It's caused by IgG autoantibodies against hemidesmosomes, which are located between epithelial cells and the basement membrane. And specifically, the antigens are what we call bullous pemphigoid 180 or BP 180 and BP 230, just different components of the hemidesmosome. Now, bullous pemphigoid classically produces tense rather than flaccid bully, and we have a picture here. And so Lakshay was completely on the money when he suggested bullous pemphigoid. Classically, it spares the oral mucosa and is Nikolsky sign negative. Because the hemidesmosomes only exist in the basement membrane, when we take a skin biopsy of bullous pemphigoid lesion and do direct immunofluorescence, instead of seeing this reticular pattern, we see this linear pattern that actually delineates the basement membrane, because all the autoantibodies are directed against the hemidesmosomes, which are in the basement membrane. So all of that should make sense. Now, most cases of bullous pemphigoid are idiopathic, but bullous pemphigoid can also be drug-induced as well. And I'm not sure if it's just Royal Melbourne. Like bullous pemphigoid is, on a population level, quite a rare blistering skin disorder. But I've spent so far 8 weeks in total on the Gen Med unit at Royal Melbourne Hospital. I've seen like 3-4 cases of bullous pemphigoid already. So you may see this as part of a Gen Med rotation. Now, so I agree, and this was the impression of the dermatology registrar who saw this patient as well. At least from clinical examination, this patient looks like he has bullous pemphigoid. Now, the treatment of bullous pemphigoid is so firstly, on the lesions itself, you can give wet dressings, apply a steroid ointment called Diprazone, and apply QV cream to it. But the definitive treatment is prednisolone plus or minus doxycycline, and usually that's quite effective in resolving the bullous pemphigoid lesions. I've had 2 patients who were refractory to prednisolone and doxycycline therapy, in which case you may need to consider other immunosuppressants, and also potentially IVIG therapy as well, so intragram therapy. But so skin biopsy was done by the dermatology registrar, and this is the report. Hopefully you can read that. But on the bottom, it gives us a diagnosis not of bullous pemphigoid, but of a condition called linear IgA bullous dermatosis, or LABD, or otherwise known as linear IgA disease. And I want to briefly, this is actually an extremely rare condition, but it makes for I won't spend too long talking about the details of this condition, but it serves as a good springboard for discussing something that's a little more high yield. So just a quick word about LABD, so linear IgA bullous dermatosis. It's like a close cousin of bullous pemphigoid. So the auto antibodies are directed against exactly the same antigen, so BP180, but the auto antibodies are IgA rather than IgG. So the clinical presentation is also extremely similar to bullous pemphigoid. You get tense lesions. The direct immunofluorescence shows a linear pattern around the epidermal dermal junction. Yeah, very, very similar in all respects to bullous pemphigoid. Now, LABD is often difficult to distinguish with another blistering disorder called dermatitis herpetiformis. Has anyone heard of dermatitis herpetiformis? You guys know which patients? Yeah, celiac disease. That's right. Yeah. So classically seen in people with celiac disease. Clinically, it's often very difficult to distinguish between LABD and dermatitis herpetiformis. Anyway. So bullous pemphigoid, LABD, very close cousins. One is IgG, one is IgA, but target exactly the same antigen. But it's important to distinguish between bullous pemphigoid and LABD because the treatment is very different. So bullous pemphigoid we treat using, as I said, prednisolone plus or minus doxycycline, but LABD is classically exquisitely responsive to dapsone treatment. And we talked about dapsone before as the second line agent for PJP prophylaxis, and we're hearing it again now. So we treat LABD with dapsone. And it's exquisitely sensitive, often signs of improvement within the first few days of therapy. So does anyone know how dapsone, so dapsone obviously is an antibiotic, but do you guys know what class of antibiotic it is and how it works? Actually, sort of on the slide. It has the same mechanism of action as sulfamethoxazole. So it inhibits dihydroteroate synthase. That's an enzyme that's part of the folic acid synthesis pathway and inhibits DNA synthesis. Inhibits folic acid synthesis, which in turn inhibits DNA synthesis. So dapsone is not just used to treat LABD. So we've talked already about two clinical indications for dapsone. So one is, so dermatitis herpetiformis you treat with dapsone as well. So one clinical indication is LABD or dermatitis herpetiformis. The second indication is, as we've discussed, second line therapy for PJP prophylaxis. Does anyone know what the third indication is for dapsone? Where else would you use dapsone? You would also use dapsone to treat leprosy. Oh, sorry. Yeah, it's on the slide. Sorry, I should have hit it. Sure. So actually, I should hide all of this. But anyway, okay. So it's on the slide. So dapsone has 5 main side effects. So the first is hemolysis. And again, especially in the presence of G6PD deficiency. The other side effect is methemoglobinemia, and there was a recent case of dapsone-induced methemoglobinemia at the Austin. Does anyone know what methemoglobinemia is? So basically, hemoglobin has 4 binding sites for Fe2+, and oxygen only binds to Fe2+. It doesn't bind to Fe3+, and methemoglobinemia just means that the Fe2+ gets converted to Fe3+. So that's methemoglobin, and it can't bind oxygen. So patients become cyanosed. Do you guys know how to treat methemoglobinemia? not quite vitamin C. Methylene blue is what you use to treat methemoglobin. Anyway, that's as an aside. Third side effect is agranulocytosis. So it chews up your granulocytes, of which there are 3: neutrophils, eosinophils, and basophils. The fourth is dapsone hypersensitivity syndrome. And this is classically associated with, so it's common in Asians, and it's commonly associated with a particular HLA genotype, HLA B1301, that I have on the slides as well. And this is actually a blood test that you can send off and is part of pre-dapsone blood. So whenever you're thinking about starting a patient on dapsone, there's a panel of bloods that you need to send off, and the HLA B1301 is part of that, just to make sure that the patient isn't at risk of dapsone hypersensitivity syndrome. And the fifth side effect is peripheral motor neuropathy. So all of these side effects, there are a couple of HLA tests that are blood tests that we commonly send off, and they're all sort of related to hypersensitivity syndromes. So actually, dapsone hypersensitivity syndrome actually refers to severe cutaneous adverse reactions as a result of dapsone therapy. So SJS is part of dapsone hypersensitivity syndrome. So all these side effects determine what bloods we need to send off before safely starting a patient on dapsone therapy. We send off FBE with differential just to monitor for potential agranulocytosis and hemolytic anemia that might develop from dapsone therapy. LFTs, so this is a bit cryptic, but we need to monitor for hemolytic anemia as well. And unconjugated bilirubin unconjugated hyperbilirubinemia is a sign of hemolysis. We also send off a G6PD level to ensure that the patient isn't G6PD deficient, because G6PD deficient patients shouldn't get dapsone. So it's contraindicated in G6PD deficiency because they are at extremely high risk of developing hemolytic anemia from dapsone. And the other thing that I already mentioned is HLA B1301. To ensure that the patient is not at high risk of dapsone hypersensitivity syndrome. So Mr. CD, he was diagnosed with linear IgA bullous dermatosis. He was eventually discharged with a plan for ongoing topical therapy. We sent off pre-dapsone bloods and then booked him in for an outpatient dermatology review in 1 week for consideration of dapsone, because G6PD and HLA-B1301 take forever to come back. And so instead of making the patient stay on the ward, pending these blood tests, thought it would be good to send them home and then for them to come back to dermatology outpatient for commencement of dapsone therapy. So quick quiz, 3 facts that you need to know about Clostridium difficile. Spore forming, strict anaerobe, and it's one of the 5 gram-positive rods. 4 classes of antibiotics most commonly implicated in Clostridium difficile infection, as we were talking about fluoroquinolones, clindamycin, cephalosporins, and penicillins. 5 clinically important gram-positive rods. Remember A, B, C, D, and L. How do you diagnose CD Clostridium difficile infection? Well, you need a patient with, the appropriate clinical presentation, so on antibiotics, and then develops at least 3 loose stools in a 24-hour period. You'll suspect a Clostridium difficile infection. You'll ask the nurses to send away a stool sample. In the lab, they'll culture the stool sample, they'll see Clostridium difficile, and then they'll do a reflex toxin B PCR. If that's positive, then you can diagnose Clostridium difficile infection, and you'll start patient on metronidazole, vancomycin, depending on severity. Main differences between pemphigus vulgaris and bullous pemphigoid. Pemphigus vulgaris is potentially life-threatening. bullous pemphigoid is less severe but annoying. I guess I won't go through all of the differences again. I think it's summarized in the table. Difference between LABD and bullous pemphigoid, they both are a result of OR2 antibodies targeting BP180. That's part of the hemidesmosome. But LABD, the OR2 antibody, is IgA, whereas bullous pemphigoid, it's IgG. Three main indications of dapsone. So we talked about dermatitis herpetiformis and LABD. The other two indications are leprosy and also PJP prophylaxis as a second-line agent. 5 side effects of dapsone: hemolytic anemia, methemoglobinemia, agranulocytosis, dapsone hypersensitivity syndrome, which is seen in patients with HLA-B1301, and peripheral motor neuropathy. And the pre-dapsone bloods are FBE, LFT, G6PD, and HLA-B1301. So, just conscious of the time. So last case, 93-year-old male, admitted with acute decompensated heart failure in the setting of valvular AF and ischemic cardiomyopathy with multiple previous cabbages. And also this vesicular papular rash on a background of myelodysplastic syndrome complicated by neutropenia and thrombocytopenia. So again, lots to unpack there. So past medical history, the patient has MDS, has 2 mechanical valves, so a mechanical aortic valve and a mechanical mitral valve. Medications are as listed, all seem pretty reasonable. Is on warfarin because he has a valvular AF. You wouldn't put patients with valvular AF on a NOAC. And social history, he's from home with wife, non-smoker, and a non-drinker. I just want to highlight indapamide. What's that? Yeah, it's a thiazide-like diuretic. Fantastic. Oh, sorry, just question, is bilirubin level routinely provided in LFT? Yeah, so LFT includes bilirubin, but often unconjugated bilirubin you need to order separately. So if you just order an LFT, they will just give you the total bilirubin, which includes unconjugated and conjugated bilirubin. Cool. So yeah, it's a thiazide-like diuretic, inhibits the sodium chloride co-transporter in the distal convoluted tubule. Anyone know any side effects of indapamide or thiazide diuretics in general? Yeah, actually, that was the main one that I wanted to highlight. Thanks, Lancelot. Yeah, so I have a patient on the ward at the moment with who presented with an acute gout flare in the setting of having recently been started on hydrochlorothiazide for her hypertension by her GP. So thiazide diuretics can precipitate gout because it brings up the uric acid levels. Cool. And the other one that I wanted to highlight was lercanidipine. Does anyone know what lercanidipine is? Also a commonly seen drug on medication lists. Yeah, what kind of CCB? Sybil? Yeah, cool. It's a dihydropyridine calcium channel blocker. So it acts on the vascular smooth muscle. There are only really two non-dihydropyridine calcium channel blockers that you need to know. One is diltiazem and the other is verapamil, and they act on the heart. What are the side effects of dihydropyridine calcium channel blockers? Very commonly asked ward round question, I find. Yes, good. Peripheral edema. There are other things like flushing, dizziness. They can also occur with dihydropyridines, but peripheral edema is the main one. Cool. Okay. So going back to our patient, this is the rash. So it started one day prior to his admission. It was initially on his face, but since spread throughout the upper torso, back, upper limbs, lower limbs, pretty much all throughout the body. We had a good look at inside his oral mucosa. There was no mucosal involvement that we could see. Was not painful, not pruritic. Any thoughts on what this could be? Yeah, could be a drug eruption. It's not classic for a drug reaction. Any other thoughts? No, it wasn't blanching. Yeah, I don't know who iPhone is, but yeah, VZV is certainly something that you need to that you need to think about. I think what's relevant is that this patient reports having had chickenpox as a child, although he denied any history of shingles later in life, and he denies having had either the chickenpox or the shingles vaccine. So these are his bloods. So a couple of things to highlight. He has very low platelets. He has low white cells and is neutropenic, actually quite severely neutropenic. If he had a fever, which he didn't, if he had a good going fever and had that neutrophil count, we'll call this febrile neutropenia, or a neutropenic fever, which is when the neutrophils is less than 1 and you have a good going fever, 38.3 or above. And this is in the context of his myelodysplastic syndrome, which is kind of the precursor to acute myeloid leukemia for those interested. Yeah, and the only difference between MDS and AML is really the blasts, percentage of blasts that you see on a bone marrow biopsy. But you know, MDS is a precursor condition. So the other things to note, renal impairment. So I had an EGFR of 19 with a creatinine of 244. CRP is not that elevated. And yeah, prolonged PT, prolonged APTT. His INR was 2.7, which for him was therapeutic in the context of AF and mechanical heart valves. Usually the INR target is between 2.5 to 3.5 rather than 2 to 3. But yeah, so his presentation is the rash and also acute decompensated heart failure. So quite appropriately had a chest X-ray done, which showed bilateral pleural effusions. We diuresed him and he got better. So it's not the heart failure component that I really want to talk about, but the rash. So this patient was reviewed by dermatology on the day of admission again. And now, in the context of the patient's known history of MDS, that's complicated by significant thrombocytopenia and neutropenia, the diagnosis that you really want to exclude and seriously entertain in this patient is that of disseminated VZV. So this isn't classic shingles, because shingles you'd expect the lesions to be localized to a single dermatome. Often in immunosuppressed patients, you can get cutaneous dissemination of VZV. And so, you know, in this case, you know, just because it's not localized to a single dermatome doesn't mean you don't think about VZV. The other thing that that dermatology were considering was a condition called sweet syndrome, which is also an important differential. And I think you know, in order to really exclude sweet syndrome, dermatology decided to perform a punch biopsy of one of the lesions that same day, and obviously to diagnose disseminated VZV. You know, the vesicular papilla lesions were also swabbed. Now, the next morning we saw this patient on ward round. We checked the swab results, and it came back positive for VZV. So this patient actually did have disseminated VZV infection in the context of significant neutropenia caused by his MDS. We also found that, so when we walked into the room, this patient was on respiratory and airborne precautions because of the disseminated VZV. But when we walked in, he had a bandage wrapped around the site of his punch biopsy, and the bandage was soaked through with blood all over his bed sheets and onto the floor. He was actively bleeding from the site of the punch biopsy, and according to nursing staff, had lost almost 1.5 liters of blood overnight from the punch biopsy site. And he has good reason for bleeding. He has very low platelets and was on warfarin therapy for valvular AF with an INR of 2.7. So his blood is very, very thin. So a word about varicella zoster virus. So varicella zoster virus is one of 8 clinically important members of the herpes virus family. So all herpes viruses consist of a linear strand of double-stranded DNA, piece of linear double-stranded DNA that's surrounded by an icosahedral capsid that's then surrounded by an envelope. And usually what happens with VZV, it enters through the mucosa of the respiratory tract. It then replicates in the regional lymph nodes, enters the bloodstream, causes this primary viremia, and then goes to the liver and spleen, amplifies up in the liver and spleen, and then re-enters the bloodstream, causing what we call secondary viremia. And then from the secondary viremia, then infects the skin, resulting in the characteristic vesicular rash of varicella, so also called chicken pox. So that's primary infection. From the skin, varicella zoster virus then classically enters the sensory neurons that innervate the skin. It undergoes retrograde axonal transport and then becomes latent in the neuronal cell bodies, in the dorsal root ganglia, or if you're talking about the face, the trigeminal ganglia. And in these neuronal cell bodies of the dorsal root ganglia, they're usually kept in check by T cells. And it's only when T cell immunity wanes that VZV then reactivates and then travels back down the sensory neurons and classically cause painful blisters, which we call zoster or shingles in the entire areal skin that's supplied by that affected dorsal root ganglion, also called a dermatome. But as I was saying, in the context of significant immunosuppression, the VZV, when it reactivates, it can undergo cutaneous dissemination. So it isn't restricted just to that particular dermatome, it goes everywhere. And classically, we see disseminated VZV in patients who had undergone a allogeneic bone marrow transplant or in organ transplant recipients. But in the case of this particular patient, he had a history of varicella zoster so it's probably has had VZV hiding latent in his dorsal root ganglia for many decades. And then in the context of significant neutropenia from his MDS, the VZV then reactivated and disseminated throughout the skin, causing the rash. So the treatment of disseminated VZV is quite simple. So this patient was placed on IV acyclovir, usually for at least 48 hours. And then once a clinical improvement is confirmed, you then step down to oral valacyclovir for a total of 10 to 14 days of antivirals. And once the lesions have completely crusted over, then you can take the patient out of airborne and respiratory precautions. So that's the definitive therapy for disseminated VZV. In this patient's case, this patient also had subcut injections of filgrastim to help with the infection. Does anyone know what filgrastim is? Oh, so Joyce, so INR usually, in patients with valvular AF on warfarin, the INR target is usually 2 to 3, but in patients with mechanical heart valves, it's usually 2.5 to 3.5. But yeah, so filgrastim is GCSF, and what does it do? And why might this patient have been given GCSF? Yeah, absolutely. So as the name suggests, GCSF boosts granulocyte count. So it boosts not only neutrophils, but basophils and eosinophils. And indeed, like after a couple of days of daily sort of subcut injections of filgrastim, this patient's neutrophil count actually normalized. And theoretically, that would have assisted with the immune response against disseminated VZV. And just an aside, GCSF was actually discovered just across the road from where I am at the moment. So across the road from Royal Melbourne, over at the Walter and Eliza Hall Institute by a guy called Donald Metcalf. So it's a Melbourne story. Cool. So one, do you use filgrastim? Yeah, it can be used as an adjunct therapy to boost neutrophil count in febrile neutropenia, but it doesn't treat the infection directly. It's not an antibiotic. Cool. So one tricky aspect of the management of this patient, which had us scratching our heads for quite some time, is his anticoagulation. So I just want to briefly revise hemostasis. So as you all should know, hemostasis occurs through 3 steps. So primary hemostasis, secondary hemostasis, and fibrinolysis. So the first step, primary hemostasis, involves platelets. So classically what happens, the endothelium of a blood vessel is breached, and this exposes platelets, which usually reside in the bloodstream, to the subendothelial matrix, so this matrix just under the endothelium that line blood vessels. And then there are glycoproteins on the surface of platelets that bind to particular components of the subendothelial matrix. The platelets become activated and classically release 2 substances. So one is 5-HT, which is serotonin. This causes arteriolar vasoconstriction to sort of limit the blood flow to the area of endothelial damage. And the second substance that platelets throw out is ADP. Which binds to ADP receptors, such as P2Y12, on adjacent platelets to activate them. So we have P2Y12 inhibitors, such as clopidogrel, which is part of your dual antiplatelet therapy. Then the activated platelets then experience a conformational change in a glycoprotein called glycoprotein 2B3A, which allows them to bind tightly to fibrinogen. So the platelet plug gets, binds to the fibrin clot that forms on top of it. And there are also GP2B3A inhibitors that we sometimes use as well as an antiplatelet. Now that's the first step. So primary hemostasis involves platelets. And then the second step is secondary hemostasis, which involves your coagulation factors, your coagulation cascade. As you might remember, there are two pathways by which coagulation cascade can be activated. The more physiologically relevant pathway is the extrinsic pathway, which is quite a short pathway. So factor 7 is produced by the liver and usually floats around in the blood. When you have a breach in the endothelium, then factor 7 then leaks out into the subendothelial matrix and binds to tissue factor in the subendothelial matrix, which activates factor 10, which then combines with factor 5 to form what we call the prothrombinase complex. And the prothrombinase complex is responsible for activating prothrombin to thrombin. Thrombin converts fibrinogen into fibrin monomers, and then fibrin monomers then aggregate to form fibrin polymers. And then factor 13A then cross-links these polymers to form and consolidate a fibrin clot. And then final step is fibrinolysis, which, as you know, involves tissue plasminogen activator, which converts plasminogen to plasmin. We have tissue plasminogen activator analogs such as alteplase that we use for fibrinolytic therapy. And the plasmin then breaks down the fibrin into fibrin split products such as D-dimer. Classically, after fibrinolysis, you get an elevated D-dimer. So back to our patient. So Mr. EF, he has AF on a background of 2 mechanical heart valves. Just emphasizing the point, warfarin is the preferred anticoagulant for valvular AF. And for patients with mechanical heart valves, current recommendation is to target an INR of 2.5 to 3.5. So this patient came in with an INR of 2.7. So technically he was in therapeutic range. But in the setting of his MDS, he was also severely thrombocytopenic with a platelet count of 35 on admission. So in terms of primary hemostasis, he doesn't really have sufficient platelets to effectively form a platelet plug. In terms of secondary hemostasis, he was on warfarin, which, as you know, inhibits all the vitamin K-dependent coagulation factors. And just a quick revision, what are the vitamin K-dependent coagulation factors that warfarin inhibits? Yeah, so TV channels, so, factor 2, which is prothrombin, factor 7, factor 9, and factor 10. And so because he's on warfarin, because all of those factors are inhibited, he's unable to effectively form a fibrin clot as well. So he can't form an effective platelet plug because he has no platelets. He can't form an effective fibrin clot because he has warfarin on board, which is inheriting factor 2, 7, 9, and 10. So it's little wonder that he bled about 1.5 liters from his punch biopsy site, which in retrospect was actually completely unnecessary because it was disseminated zoster virus. That was the ultimate diagnosis. We probably should have swabbed the patient before proceeding and checked that it wasn't VZV before proceeding with a skin biopsy. But dermatology was driving that one. So having said all of this, if his INR, so his INR came on admission was 2.7, which is therapeutic for him. If his INR becomes subtherapeutic, so it gets below 2.7, then this actually is also quite dangerous because it puts him at high risk of forming clots around his mechanical heart valves, which can then flick off to cause an ischemic stroke. So, is an INR of 2.7 appropriate for this patient in the context of severe thrombocytopenia and in the context of the patient just having bled 1.5 liters of blood from his skin biopsy site? Or should we be targeting a slightly lower INR until his platelet improves? And naturally, so this had us scratching our heads for quite a long time. Naturally, we consulted hematology on this issue. They discussed it at length with multiple consultants and ultimately recommended a slightly lowered INR target of 2 to 2.5 if the platelets were below 40, which it was on admission. And if the platelet count ever rose above 40, then to target the normal INR target of 2.5 to 3.5. So, I didn't talk about the 8 clinically significant herpes viruses, but does anyone know the 8 herpes viruses? Varicella zoster is one of them. Does anyone know what the first herpes virus is? HSV1, yes. Second, HSV2, good. Third, VZV, fantastic, causes chickenpox and shingles. Fourth, EBV, fantastic, causes glandular fever, infectious mononucleosis. Fifth, no. So fifth is cytomegalovirus, so CMV, which sometimes causes CMV pneumonitis in immunocompromised patients. 6 and 7 are called human herpes virus, so HHV 6 and 7. They cause rosella, as Jason mentioned. And the last one is also just known as a number. So HHV 8, which, do you guys know what HHV 8 causes? Yeah, Kaposi sarcoma, fantastic. How do you treat disseminated VZV? Well, at least 48 hours of IV acyclovir, then step down to oral valacyclovir when clinically improved for a total of 10 to 14 days of antiviral therapy. What is filgrastim GCSF? What is it used for? To boost neutrophil numbers. What coagulation factors are inhibited by warfarin, the TV channels, so 2, 7, 9, and 10. And what INR target is appropriate for patients with AF and mechanical heart valves on warfarin, 2.5 to 3.5. Cool. Sorry, 3 minutes over time. But this brings us to the end of the first virtual ward round series. The next virtual ward round will be on infectious diseases and is scheduled for Thursday, 2 weeks from now. So these virtual ward rounds are delivered fortnightly, always on a Thursday, 5:30. So the next one will be on Thursday, 12th of August from 5:30 to 7:30. So to sign up, the link the try booking should already be up. So just scan the QR code on the left to sign up. And if you want to follow, keep abreast of all, tutorials and lectures that our TFI medicine team has to offer, scan the QR code on the right to follow our TFI medicine Facebook group. And yes, thanks for joining in the discussion tonight. And hope you learnt a thing or two, and look forward to seeing you guys all next time. Thank you.